you've had a nice talk there on rotator cuff tears, and my charge here is to talk a little bit about on healing and how we may use some techniques in the future to augment the biology of healing. Dr. Tori nicely went through the mechanical factors. I'll talk a little bit more on the biology side of tendon healing here. Here are the disclosures that relate to this. So when we have a rotator cuff tear, as you see here, we go ahead and do a repair like this. What we'd like to do is regenerate the normal tendon to bone insertion site, which is a highly complex tissue, a gradation from tendon through fibrocartilage through bone. But a factor we get when we do these repairs is really this fibrovascular scar tissue interface. We don't reform this normal tendon to bone attachment site with our repairs. Our goal will be to recapitulate the events that occur during embryonic development. How can we have our tendons recreate this normal insertion site? That's our charge this morning. So why does this happen, and is there anything we can do about this? I think a lot of the biology of tissue healing, not just tendon healing, but other tissues, relates to considering the inflammatory response. This is, of course, a generic response to surgery. And there are a number of cell types, of course, that are involved, a number of different inflammatory mediators. They're all part of the inflammatory process following surgery. A number of different tissues are affected. There's bone, a number of different cell types. We have different mediators such as matrix metalloproteinases. There are reactive oxygen species that cause oxidative damage. We see these inflammatory mediators such as IL-1 beta and TNF-alpha. All of these factors are part of the inflammatory response that occurs in response to surgery. Well, one of the fundamental biologic effects of inflammation is healing by fibrosis, essentially scar formation, rather than tissue regeneration. So again, all these cell types and all these mediators, what they lead to here is scar. So when we repair a tendon, we are getting really this fibrosis, this scar forming, rather than regenerating a normal complex insertion site. So some thoughts about that. I think we can learn lessons from fetal wound healing, so-called scarless healing, which occurs due to the absence of an inflammatory response. In the developing embryo, before birth, if a wound is made, that tissue regenerates in a scarless fashion. It's a fascinating process. We can learn lessons from developmental biology. And the goal here is, can we use the molecular signals that direct tendon formation during development to learn lessons about how we might improve tendon healing? So we can start by talking about the topic of cytokines, growth factors, and these important molecules that have a role in tissue formation. As an example, BMP12, we've looked at this in our laboratory. This is part of the family of growth and differentiation factors, so-called BMP12 and BMP13. We looked at BMP12. These factors act as signaling molecules during embryonic tendon and ligament formation during embryogenesis, during formation of the tendon insertion site in the developing embryo. So we went to a sheep model. We did infraspinatus tendon repair, detached the tendon, and then reattached it, and we applied BMP12 on a collagen sponge carrier, as you see here on the slide, and looked at these animals out at 8 weeks. What we find is that there was a distinct improvement in the fibrocartilage formation at the repair site. The BMP12 treated limbs on the right side of the slide, you see a more robust zone of fibrocartilage. The animals that had the BMP12 had improved tendon repair strength. That's the two in the middle here are BMP12 delivered on a collagen sponge carrier, nearly 3 times as strong as the control tendons. And there's a positive correlation between the glycosaminoglycan content at the repair site and tendon strength. So BMP12 seems to have some promise here. But what is available today to impact this biologic failure? Again, these growth factors are all experimental right now. What can we use today? Well, certainly no talk is complete without discussing PRP. PRP is one method to apply cytokines to healing rotator cuff tendon. And the attraction of PRP is the ability to deliver numerous cytokines in physiologically relevant proportions. It's been looked at quite a bit in the setting of rotator cuff repairs. There's some pictures of using a platelet-rich fibrin matrix applied at the tendon bone attachment site. The data right now, if you look at all the literature, is inconclusive at best. I'll show you some representative studies. Alan Barber in Texas, this is a case control study, 2 match groups of patients, 20 patients each, either standard repair versus repair plus a platelet-rich fibrin matrix, so-called PRFM. And he found these MRI to look at recurrent defect. He found that the control group had a recurrent defect in 60%, while the PRP group only 30% had a recurrent defect. Smaller tears, less than 3 centimeters, controls had a 50% defect, whereas PRP group only 14%. So he found overall here, positive results using PRP at the time of rotator cuff repair. Now, we carried out a study at Special Surgery in New York, myself and Russ Warren, a randomized trial, 79 patients. About half of these got this platelet-rich fibrin matrix at the repair site, half had just a standard repair. Overall, we found no difference. We see no differences in outcome scores, standardized outcome scales. We see no difference in strength, no difference in tendon vascularity as measured with ultrasound. We saw no differences in healing measured early at 12 weeks. The rate of intact tendon was 67% in the PRP group versus 81% in the control group. And in fact, the platelet-rich fibrin matrix was a significant predictor for a tendon defect at 12 weeks. So in fact, suggesting a potential negative effect in our study. Another recent study, Stephen Weber in Sacramento, very similar to our study, 60 patients randomized to either a platelet-rich fibrin matrix or just standard surgery, and they see no difference in the standardized outcome scales, no difference in motion. Using MRI, they found no differences in the rate of recurrent defects. So they concluded overall PRP had no effect. And this is a table from their study just demonstrating and summarizing a number of different studies that have been out there. If you just look at the column clinical outcomes, in general, no real difference. And the column on the far right, imaging outcomes, again, in general here, no real differences. So no firm evidence that the PRP improves rotator cuff tendon healing. This is a summary from a couple of years ago where the authors concluded PRP does not have an effect on overall re-tear rates or shoulder-specific outcomes after arthroscopic rotator cuff repair. Now, there have been some positive studies out there, but there's a number of negative studies. So on balance, it's hard to make any recommendations. I think a fundamental limitation of PRP is a tremendous variability between different PRP formulations. We know that PRP varies in the platelet recovery, in whether or not white blood cells are included in the preparation. There are variations in how or when platelets are activated. There's also variability between patients. You know, my PRP is different than your PRP. Platelet counts vary markedly between patients. In fact, platelet counts vary day to day within an individual. If you take your blood right now and measure your platelet count and then do it again tonight, it would be quite different potentially. There are differences in the growth factor content per platelet. And there are also other factors in the plasma outside of platelets that may play a role. All of these factors contribute to the variability in studying PRP, and this just gives you a sense of all the different commercial systems that are available, lots of variability amongst these systems. So how might we improve PRP in the future? Well, I think we need to think about identifying the factors that have a positive effect. What are the particular cytokines or other plasma proteins that can have a positive effect? Maybe we should have techniques to remove unwanted cytokines. There are also inflammatory mediators such as IL-1 beta that maybe we should remove from PRP. We need further study of the role of white blood cells. People talk about white cells, and there's a number of different white cell phenotypes. There are monocytes, there are lymphocytes, there are neutrophils. These cells are all very different. We need to figure out what cells have a positive effect and which do not. The timing of cytokine presence is critical. Should we do one injection or should we do repeat applications of PRP? And lastly, maybe we need to combine PRP with cell delivery. Further reasons for the limitation of PRP are as follows. Cytokines, growth factors that are contained in PRP, these can increase production of tendon matrix proteins, but a critical deficiency is that the tendon microstructure is not reformed. Cytokines improve the structural properties by inducing more essentially scar tissue formation while not improving the material properties of the tendon. So while it appears that growth factors such as PRP still do not provide the proper cellular and molecular signals to drive regenerative healing, and thus my hypothesis is that both pluripotent cells and the appropriate signals, such as from PRP, are needed to reconstitute both tendon composition and structure. And this leads to the topic of cell-based approaches to augment tendon healing. Certainly this is another area, a hot topic that has great potential in our field. Cell-based approaches, the implanted cells that we put in may function in one of three ways. Cells may directly participate in the repair process. The cells themselves may have a paracrine effect by stimulating other local or distant cells. And lastly, implanted cells may have an anti-inflammatory effect. Cells can work in any of these mechanisms. And if we put cells into rotator cuff repair, They may aid tendon to bone healing. They may aid tendon to tendon healing. And they also may have some effect on muscle regeneration and potentially reversal of the fatty atrophy and the fat infiltration that we see in the muscle in rotator cuff tears. So where are we today with cell-based approaches? Well, we have 4 different options we can consider both now and moving forward. The most common and only way we can really do it now is adult-derived cells derived from either bone marrow or fat tissue, adipose. These are the only techniques that are available at this time. In the future, we may be able to use induced pluripotent cells, and these are cells that can be formed by reprogramming differentiated adult fibroblasts to essentially taking like skin cells and transfecting them with these 4 specific genes and making these cells act like a stem cell. Certainly embryonic stem cells are another potential source. They have different ethical and regulatory issues and so are not available at this time. And lastly, we do know that there is a stem cell niche in many tissues. Many tissues, including rotator cuff tendon, have intrinsic stem cells. Our challenge is to figure out how to leverage those cells, how to stimulate those cells, how to localize those cells, and have them participate in the repair process. Just to show some of the potential here, Alan Nixon at Cornell University has used a horse model. He used a collagenase-induced tendinitis. You essentially take a flexor tendon in the horse, inject some collagenase, and you get a tendinitis-like condition in the tendon. Then he used adipose tissue and isolated essentially the nucleated cell fraction, so stem cells, and he injected these cells 2 days later into these horses, into these collagenase-induced tendinitis lesions. And what he finds is quite interesting. If you look at the histology of the tendon at 6 weeks, the bottom half of the slide shows the stem cell-treated tendons. There is a reduced inflammatory cell infiltrate. There's an improvement in tendon fiber architecture and the overall organization of the tendon. And there's a more normal crimp pattern. The slide in the lower right demonstrates histology under polarization, showing this normal crimp pattern in contrast to the disorganized tissue in the untreated tendon. So cells here really had a positive effect. So based on this, we went to our rat model in our laboratory in a series of studies. We have a rat rotator cuff repair model, essentially detaching and then repairing the tendon. It's a simple and standard model that's been used. We use bone marrow-derived stem cells and a fibrin carrier, and we place these at the repair site. We looked at our animals at 2 and 4 weeks, and overall, we found that cells alone did not improve healing. So on our hands, it didn't do much, both based on biomechanical testing, load to failure, or histologic evaluation of the healing tissue. So it seems that cell-based strategies may need to be combined with growth and differentiation factors to be effective. Cells alone may not be enough. So we went on in this model and took these same cells, same model, and we looked at scalaxis. Now, scalaxis is a transcription factor that is expressed in all developing tendons and ligaments. It's crucial to tendon development during embryogenesis, so we said this might be an important factor to look at. We use gene therapy techniques using adenovirus vectors to transfect our stem cells with the gene for scalaxis. And in fact, we find now an improvement in healing. Histologically, on the left side of the slide, you see the bottom half is the scalaxis-treated animals, a much more robust fibrocartilage zone compared to the controls. And on the right side, biomechanically, that translated to increased load to failure and stiffness at 4 weeks in the animals treated with these transduced stem cells. So taking the cells and putting this particular signal in led to a positive outcome. How about clinically? Where are we today? Well, this is a nice study Philippe Pernigout from Paris recently published, 45 patients using concentrated bone marrow-derived MSCs. The average number of implanted cells was 51,000. They compared this to a matched control group of 45 patients with no stem cells. And what they found is that the cell treatment enhanced the healing rate and improved the quality of the repaired tendon as determined using ultrasound and MRI. At the 6-month post-operative point, 100% of the repairs with stem cells were healed, compared to only 67% in the control group. And then he looked at a 10-year follow-up in this study, and he found the intact rotator cuffs were found in 87% of patients who had received cells, whereas an intact rotator cuff repairs only found in 44% of the patients in the control group. And in fact, the long-term rotator cuff integrity was better in those who received a higher number of cells. So this is strong clinical evidence to support the role of cell-based approaches in improving healing. Patches, I won't spend much time on this, but these extracellular matrix materials that have been used to augment repair, I would submit to you they may be used as a delivery vehicle for either cytokines or cells. At the end of the day, the best approach may be to combine patches, maybe plus PRP, plus cells. We need further data to figure out how to do this, but these patches by themselves haven't been highly effective, but perhaps they can serve as a carrier vehicle for cells or cytokines. Lastly, what about some systemic factors that may affect tendon healing? Inflammation, again, we talked at the beginning, critical. We have found that inhibition of inflammation using non-steroidal medications impairs tendon-to-bone healing in animal models. Even though I mentioned that inflammation leads to scar formation, that's the only way the tissues heal. So if you block inflammation, it has a detrimental effect. This is some work we did some number of years ago in our rat model, treating the animals with Indocin or Celebrex, and we found that both of these anti-inflammatories impaired tendon healing because you block the inflammatory process. So perhaps non-steroidal medications in the early postoperative period have an adverse effect on tendon healing and should be avoided. In the future, we need more specific ways to modulate the inflammatory response. Non-steroidals are very non-specific. They knock out a lot of different molecules and a lot of different mediators. We went back to our model and we used a drug that blocks TNF-alpha, so Enbrel, which has been used by our colleagues in rheumatology as a TNF-alpha blocker. In fact, we found if we did our rotator cuff repairs and blocked TNF-alpha, there was an improvement in healing. So this is a more specific modulation of inflammation. What about MMPs? MMPs are matrix metalloproteases. This whole inflammatory process leads to upregulation of MMPs, and these enzymes lead to decreased structural and mechanical properties in tendon. MMPs can have an adverse effect on tendon quality, on tendon strength. Steve Arnoxley showed a lot of this. We know that MMP inhibitors have the potential to prevent ongoing tendon degeneration. So we went back to our simple model and used doxycycline, which is an antibiotic, as you know, that has broad-spectrum MMP inhibition activity. We gave our animals doxycycline, and in fact, we find an improvement in healing. The control animals are in the black there, and the drug-treated groups are the other bars, and we see an improvement in load to failure that's significant at 2 weeks in animals given doxycycline. So by blocking MMPs, we improve healing. Again, we're not ready to use this clinically. This is all preclinical data, but these are some pathways that we can explore to ultimately try to improve healing in our patients. So what are some implications for treatment? Well, there are some novel agents that we know can block either inflammatory mediators or MMPs. Some are listed here. Our colleagues in rheumatology, of course, use TNF-alpha blockers. There are drugs that block IL-1 beta. There are MMP inhibitors that are being developed. None of these are ready for widespread use in the shoulder, but I think I would submit to you these are avenues that require further research and have potential for us to modulate the biology of tendon healing. What about bone metabolism? We know the tendon-to-bone healing proceeds by bone formation at the healing interface. Essentially, bone grows into the tendon. So maybe methods that can impact either osteoclastic or osteoblastic activity could improve healing. We may modulate osteoblastic activity with drugs that are available today. Vitamin D is something we can think about. Parathyroid hormone, known as Forteo in the U.S., or teriparatide. What about modulating osteoclastic bone resorption with bisphosphonates such as alendronate? Well, vitamin D does seem to have some role. A nice study published several years ago looked at 366 patients with a shoulder MRI. 228 patients of these had a full-thickness tear. 138 had no tear. And they looked at these patients, and the vitamin D level was an independent variable for fatty degeneration of the rotator cuff. In fact, they found lower serum levels of vitamin D were related to greater fatty degeneration in the rotator cuff. And in fact, serum vitamin D level was a significant positive correlation with muscle torque. So vitamin D may have some role here in tendon and muscle biology. We went back to our rat model again and induced vitamin D deficiency by using a specialized vitamin D deficient diet and ultraviolet light filters to remove UV light. And we found that we could in fact drive the vitamin D levels down in our animals. So we can make a vitamin D deficient rat, and we did our simple supraspinatus detachment and repair and looked at these animals at relatively early time points, 2 and 4 weeks, with histology and biomechanical testing. And we find that there's a significant difference in the ultimate load to failure between the control group and the vitamin D deficient group. The vitamin D deficient animals were weaker. There's lower tendon repair strength at the early time point with vitamin D deficiency. That was supported by histology. We found less bone formation and less collagen fiber organization in the vitamin D deficient specimens at 4 weeks compared to controls. So in conclusion, I think the poor healing response there may be due to MMP regulation or the influence of vitamin D on new bone formation at the healing tendon bone attachment site. Vitamin D regulates MMP9. One last study to show you, we looked at parathyroid hormone also in our rat model. Again, our repair model, we gave the animals parathyroid hormone daily for 2 weeks. And we find the group that gets PTH has greater total mineral content at all time points. We found more fibrocartilage and bone formation at all time points in the animals given PTH. Although there was no difference in load to failure, the specimens with PTH had significantly higher stiffness. So PTH does have a positive effect when given, again, in this small animal model. Lastly, what are some factors that have an adverse effect on healing that we should consider? I list them here. Hypercholesterolemia has been found to have an adverse effect. Smoking, you just heard in the last talk, clearly has a negative effect on tendon. Diabetes, we see higher failure rates in the patients with diabetes. Osteoporosis, there are higher failure rates of repair in patients with osteoporosis, and again, a vitamin D deficiency. All of these are things that we can think about as clinicians because these have an adverse effect on tendon healing. So lastly, my current approach to optimize healing, I do not currently use PRP. I recommend avoidance of non-steroidal medications in your first 4 weeks. Consider checking vitamin D levels. This is a modifiable risk factor. Clearly encourage smokers to stop smoking. Diabetics, we should aim for strict glucose control prior to surgery. And lastly, we should think about exogenous cells. These certainly have promise, and maybe in the future we'll combine cells with PRP. Thank you.